So you don't get a lot of chance to sit down and talk to two physicians who have been treating prostate cancer for more than 20 years and who have also each had it for more than 20 years. So what we're going to try and do is squeeze out of Paul and Snuffy this afternoon everything they can tell us about what they did well and what they did badly. I don't think they did too many things badly, but you know. So this is pretty much going to be first a little bit of a conversation between me and them, and then we're going to get you guys to start asking them questions, and hopefully we can get as many questions asked as possible. So we'll begin with Paul. Paul, could you just sort of talk people through your own initial diagnosis, and the high or low lights of what you've been through?
So I guess I'll start out with a statement that you hear so frequently these days, that words matter. And it has to do with my initial diagnosis against the background of the other old man's disease, which is cardiovascular disease. So when I was 58, I had a rather acute onset of chest pain and an occlusion of my LAD, which is a major coronary artery, a rather significant occlusion. For those of you who've had similar, it's called the Widowmaker for those reasons. Well, I was thankfully appropriately quickly treated. I went on to cardiac rehab, a diet, statins, and felt that I was partnering with my heart to a better and more optimistic future. 2 years later, I was diagnosed with prostate cancer, and I was rather surprised how different the reaction was. A much more visceral and anxiety-filled reaction because of the word cancer. And the reason I was surprised is I'd lived with that word for decades. I had spoken with many patients about it. I knew prostate cancer as well as probably any urologist because that was my focus. And I realized that this was a disease that wouldn't threaten my life for years and maybe decades, whereas heart disease could be an overnight threat. But yet the sense of, I'll say, betrayal about having this cancer label was quite significant, and I really wanted to do something to get this alien invader under control. So I just now, when I speak with physicians, tell them that no matter how well educated the patient is or how well read and how much he's heard the cancer term, when it hits home, there's a different emotional response. And I kind of equate it to the, we'll say, the playing field versus the practice field, or the battlefield versus boot camp. In boot camp, you learn what to do and how to do it, but until you're in the heat of battle, you realize that there have to be adjustments and there's not just quite the same equanimity. So the lesson is cancer, yes, is a prostate cancer, yes, is something that we can deal with, fortunately, for decades in treating, but still it does certainly upset the mindset, the apple cart, and your sense of equanimity, and we have to take that as physicians very seriously.
I was 55. I had been working, specialized in treating prostate cancer patients for 12 years. And in that era, prostate cancer was not supposed to be common under 55 unless you had a family history. And so there was a back and forth with my wife. Snuffy, go get your PSA tested. Rose, I don't need to worry about it. I'm a young guy. There's nobody in our family that had it. Of course, we now know that's not true. My brother also has prostate cancer. So, finally, she told me that I could sleep in the garage if I didn't get my PSA tested. Well, maybe not quite that bad, but so 20 years ago, this February, I went and had my PSA tested. So I had the PSA test done, and it was 20.4. My urologist, which is a female urologist I'd worked with other patients, did the prostate exam and said there was a large mass on the left side of my prostate, and the biopsy showed that the capsule had been penetrated. The left seminal vesicle was involved, and lymph nodes in the left side of my pelvis were positive. There was a young investigator there then at the time, Dan Theodorescu, who's gone on to great things in urology, and he had set up to do circulating tumor cells and found tumor cells in my blood and bone marrow. So I knew quickly I was in trouble. Given the statistics at the time, I had roughly a 5% chance of being alive at 10 years. And so I decided to become very aggressive. And, I took at the time what would have been considered out in left field because I did hormonal therapy for 18 months and radiation to my prostate gland and the pelvic lymph nodes. But now that treatment doesn't sound so far out. I came off hormonal therapy in the summer of 2000. As my testosterone recovered, my PSA went up. I did a course of leucine, and over a 2-week period, my PSA went undetectable and stayed down for below 0.01 for the rest of the time, until today. I continue to have circulating cancer, prostate cancer cells in my bloodstream. The number doesn't change as time passes. When the Garden 360 test came out, it picked up mutations in the cancer cells characteristic of prostate cancer, but the amount of those cancer cells also hasn't changed as time passes. So I'm in what we call a durable complete remission with a cancer that is dormant but not absent.
What did you first do after you got diagnosed? I think you went out to the University of Washington.
Yes, well, listening to,
I'm sorry, I asked him what he did after you first got diagnosed.
so I did have a radical prostatectomy, open, because at that time, neither laparoscopic or robotic were present in the USA. And listening to Snuffy's story is interesting because he had, and we've mentioned today that every body is different and every cancer is different. He had a number of prognostic features which, as he said, were really ugly for aggressive cancer. My cancer, when it was removed, was confined to the prostate. It was high, Gleason 4+4, but my seminal vesicles were negative, my lymph nodes were negative, and I had 20 of them removed, so it was a good sampling. But unlike his situation, which then, I'll say, became quiescent over the next decade or more, I developed a PSA failure about 2 years out. I had what was traditional salvage radiation with some androgen deprivation for 6 months, then 3 years of quiescence, then another PSA recurrence. And I might add, the first PSA failure was almost as viscerally uncomfortable as the original diagnosis, because like everyone, I'd hoped that that radical prostatectomy was going to cure the disease. Now, cure is a very evanescent word with cancer. And when I had the rising PSA after the radical prostatectomy, well, I realized that I was in it for the long haul, and that ticking clock, even though in the background, was going to be ticking. So I went on to androgen deprivation therapy, continuous, and then subsequently developed metastatic disease to my vertebrae, for which I had stereotactic radiation. I went on to Provenge, enzalutamide, Zytiga, all the medicines that you know about. And for some reason, the cancer became somewhat quiescent for 3 or 4 more years. So this brings me up to the current time where I had one of those axiom scans that you heard about today, because the PSA went up to 3 and 4. And I have one solitary node in the pelvis that is now active. So the bone, by the way, had been biopsy confirmed. So there was no question about this being arthritis or some other degenerative disease. This was prostate cancer in my vertebrae. But the treatment I've had has resolved those issues, and for some reason there's this node that's been there forever, because it must have been there from day one, 18 years ago now, is the only active area. So I'm going to be thinking about how to treat that in the future. But it shows that both Snuffy and I are still here, even though our courses have been different, and I think we attribute it to doing some active therapy and investigation and application over that time frame.
Now, obviously, Snuffy and Paul did not have to go through some of the educational processes that you have had to go to because they knew all this when they started. On the other hand, what I want to point out is all the other things they've been doing while this has been going on. Snuffy, for years, treated a whole bunch of people, some of whom are here. Paul also. Paul went on to become the chairman, the president of the American Urological Association during this time period. He's been the president of the Society for Urologic Oncology during this time period. And one of the things I want to leave you all with when you go away from here this evening is you can go on leading a highly productive life after a diagnosis of prostate cancer. So, Paul, talk to me a little bit about sort of how you thought about all this and what you were trying to do for yourself over this time period. I mean, I know I asked you this at a previous time we did something like this. I said, how many of the bizarre things that you could do and take did you do it? I mean, I remember you telling me, well, I spent a lot of time taking a lot of pomegranate juice. I don't know that either of us actually know whether it did any good or not, but I think it's very representative of the sorts of things that patients are going to do to try to be as well as they can. Is that a fair comment?
Yeah, well, it's a fair question because you're always looking for something more and beyond what, say, is the traditional lineup of therapies. You don't want to disregard those or put those aside, but what more can you do? And there's been some tantalizing evidence, and Dr. Myers has been a leader in this, and a number of commonly used drugs. I'll include statins, I'll mention metformin, vitamin D, pomegranate juice, 3-omega, and I'm not advocating that all of those are appropriate, but they are things to look at and to discuss with your physician. I will say, based on what Mike mentioned about living well with cancer, there's a book by a gentleman, Mukherjee, called The Cancer, the Emperor of All Maladies, and he says, if we're going to win the war on cancer, we need to redefine the meaning of victory. And I think most of us think of victory as cure of the cancer, as opposed to recognizing, again, cure may not be possible or realistic, but living well with that cancer is very possible and realistic. And unfortunately, I think the battle metaphor, the war metaphor that's often used for prostate cancer patients is a bit of overkill because you cannot get up every day in a battle mindset. It's exhausting, it's energy depleting, it drains your resources, and so it's a negotiation more than a pitched battle. And I'll ask Snuffy what his thoughts are with regard to living well as also.
Well, after my testosterone recovered in 2001, I decided to retire from my position at the University of Virginia, where I was director of the Cancer Center. And that struggle no longer made sense to me. And so I went home. And so here I am sitting home. I'm in remission. The PSA is at that time undetectable. But I know I've got terrible statistics. So it's like I'm sitting there waiting for the bomb to go off. And so I decided to open the practice that I did as something to do while I waited for the cancer to come back. And of course the cancer hasn't. What I found in the process of, now I was a patient, and I wasn't curable, is that I could understand the patient's problems better than I ever had before. This was no longer a disease you had. It was a disease we had. And I found the act of caring for other patients with prostate cancer emotionally very rewarding. And I learned a lot over the years that has benefited my own management. So it was just a very interesting process. It wasn't planned. It just happened.
So I don't have prostate cancer. I should be very clear about this. I got into this completely by accident. But one of the things that I've noticed from talking to a lot of men over the years and to some of their wives is that having prostate cancer is kind of like getting married. Sometimes you don't know who you're marrying quite as well as you think you do. And so it takes time to sort of build a relationship that you're both comfortable with most of the time. And that doesn't mean there won't be bad days, because, gee, guess what? In most marriages, there are bad days occasionally. But you learn to live with it. So are the days you wake up and get up in the morning and you don't think about it at all?
Absolutely, yes.
Right.
In fact, originally I used to plan my PSA numbers. This is originally away from any important events. So the week after Thanksgiving, the month after Christmas, the month after a birthday, because I didn't want that PSA to be foremost in my mind while I was trying to participate in some other important events. As the years go by and you become accommodated with the interaction, gosh, I don't worry about that PSA. Even when it's drawn, I don't hunker down and look the next day to see what the result is. I just wait for it in the mail and recognize what will be, and then you make the next decision point. So for me, I waited until the PSA drifted up to 3 or 3.5, 4, and then I got the scan, and now I have another decision to make.
Are the days you wake up and you can't think of anything else?
We call it prostate-specific anxiety. Well, I'm torn. I can't wait to find out what it is, because I don't know what's happening. Is it good? Is it bad? And then I'm terrified about what I'm going to find out.
How much of what you both do now is still driven by your medical curiosity about, what's on the horizon that might really help?
Well, it's 2 phases. First, I'm scared to death first. Then I calm down and start thinking.
Does that happen to other people?
Well, I'll say there's so many other. I mean, I'm 79. I don't know, Charles, what your age is, but we're kind of faced with all of these, we'll say, possible roadblocks to better health and survival. It almost seems that prostate cancer settled into, well, will it be heart disease or will it be something else, a stroke? And so its preeminence in my list of problems has settled down along with the others as opposed to being on top of the list as it was when I was 60 when I was diagnosed.
Okay, so let's see what questions we've got from the audience.
Over the years, has the PSA reliability increased, decreased,
All the PSAs have become much more accurate, precise. The technology's gotten wonderful. Yeah.
I just want to know if it seems obvious, but have either of you felt that you've had any cognitive decline because of any of your treatment? Be honest.
Neither of us are willing to say yes. No, again, it's hard to determine that in the progression of aging. Now, I have, and I have to admit to this because it's a little bit unorthodox, and it's the man to my left who told me after I was struggling with the traditional LHRH, Eligard, Zoladex, Luprons, to use estrogen. And estrogen had a very bad name in the past because it was taken orally and led to increased number of cardiovascular thromboembolic events. But it's now deliverable transdermally, and many women here may take a patch once or twice a week to prevent hot flashes of menopause. A much higher dose is necessary to suppress your T level, but I went on that at Snuffy's recommendation, and I will say I felt better. And I have maintained that as my regimen for quite a few years. But I don't think I would say that I've lost too much of an edge. My memory isn't what it used to be, but then again, I'm 79. I'd expect to not remember the name of the folks who played in the movie I hope I can remember.
I'm frustrated and very angry because they're treating my husband like they don't think he's bad enough to treat with chemo, so they're waiting for him to like almost be dying before they start treating him. Why is that? And why can't they do something now? They can't see, he had the seeds put in, and now it's recurred only because they think because of the PSA, but they can't see the cancer in there because the CAT scan or the MRI gets a flashback from the seeds. So they're assuming that he has it again because of the PSA, but they don't want to do anything because it hasn't spread to anywhere. And why should he have to wait until he's almost to the point of,
This is where the huge advance in imaging helps. The PSMA scan, the Oxygen scan.
but they can't see it because of the seeds. You know what I mean? They can't see his prostate, the inside, because
But the Axiom scan is not based on that. Certainly an MRI or a CT scan would be problematic, but the AXU-IUM scan, not so.
I've actually come across this problem before, Paul. I'm not sure whether the Axiom scan works as well if you've had seeds. I mean, I'm not, because the seeds may cloud the results.
But it would seem that there's a lot of other, maybe exactly in the pelvis, right around the prostate, but for metastatic disease.
Oh, no, for metastatic, I don't
Yeah.
think it's an issue. I think this lady's husband's probably still relatively localized, or is it truly metastatic? So when you're saying they won't give you chemo, are they saying they wouldn't give you docetaxel chemotherapy, or are they saying won't give you Lupron?
It's a localized recurrent prostate cancer. They can't see this. They can't see the tumors in the prostate because the seeds reflect so much light in the tests, and they're basically waiting for it to metastasize so they can attack the tumors as they metastasize. But if you don't kill the tumors in the prostate, it's going to continually slough off seeds and continually metastasize to other places in the body. So the frustration is they can't attack the cancer in the prostate at this time because they cannot see it, they cannot biopsy it.
So his PSA has gone from 0.009 up to about 0.34 now over about 12 tests. So that would be over 4 tests a year. So it's over about 3 years. Is this a case, Snuffy, where giving somebody anti-androgen therapy alone might be something you could talk to somebody about? Have you been somewhere else to get a second opinion? And they're all telling you the same thing.
Well, I think, Mike, this is brachytherapy. There's a bounce after brachytherapy in the first 3 years. 0.34 is not, in my mind, a worrisome number. And so I'd be happy to speak with you all about how I would go about it, without having an audience. But I'm not alarmed by what you're telling me if I know the whole story, but I'll speak with you afterwards.
It seems to me that it's not clear from the information you've given us that you've actually relapsed. Mm-hmm. The PSA. Does the PSA show a clear doubling time? Because PSA can go up after brachytherapy.
Yeah, 4 years after the brachytherapy, I hit my nadir, and for the next 3 years now, it's been progressively going up. So the rising PSA has not slowed down at all. It's gone up.
It's still under 0.5.
Yes.
In this setting, your best option is to get a careful scan. If you can get PSMA or the Oxman scan done.
If
when
you,
your
if
PSA
you,
hits
where do you live, sir?
gets above 1 or 2.
So if you went up to the National Cancer Institute and you talked to the people up there, they could there's at their clinical center in Bethesda, you could probably get something like a gallium PSA scan or an Axiom scan done under the very best possible standards. And that might help to resolve the issue because it might show either nothing or something. But the real problem is without something to treat, it's very difficult to know what to do, and I think in some ways what the doctors may be trying to do is protect you from being overtreated too early. They may not be good at explaining it, that's a whole other issue. Well, there are various different tests. The great advantage of going to somewhere like the NCI Clinical Center is that everything that is in clinical trials or investigational, they have access to. So they could evaluate your husband and say, we think we can give you test X that might not even be approved anywhere else in the country. And I mean, he'd probably be an interesting case to them. And it's free, because it's at the National Cancer Institute. The lady's asking about whether you can provide her with information about a study about the use of metformin that she could take to her doctor in order to be able to say, is this something that might be appropriate?
Well, actually, Paul sent me an email when he picked up the paper. It was the European Journal of Urology, and it was looking at Lupron versus Lupron plus metformin. Now, when you put patients on Lupron, hormonal therapy, people who get fat, they can get metabolic syndrome, they can get hypertension, they can get prediabetes or diabetes. And so this trial was to see whether metformin would have a favorable impact on that adverse aspect of hormonal therapy. And there was also very clear metformin had a dramatic benefit in terms of the metabolic side effects of hormonal therapy. After that paper, it became standard practice for us to evaluate patients who came to our clinic for the risk for diabetes, pre-diabetes, etc. And if they were at risk, we'd put them on metformin with the initial Lupron treatment. And it really made a huge difference in terms of cardiovascular risk. And in that setting, I can't comment definitively about therapeutic impact because it wasn't randomized. And the randomized trial was looking at reducing the side effects of treatment, not at the therapeutic part. Right now, there is no convincing randomized controlled trial that shows metformin has anti-cancer activity against prostate cancer. It simply hasn't been done.
But there are observational studies that would lend you to think that that's a possibility, and that's why this MAST trial that I mentioned, but that's for patients with metformin active surveillance trial, MAST, but that's for the active surveillance group. So again, when you ask about a clinical trial, you have to then ask what disease state you're in and have to go to the NCI database to look if you fit into the niche that they're studying. But as Snuffy says, in the meantime, if you're on ADT, it's a benefit for the side effects that you accrue from ADT. So if you win on that score and then win also possibly on a survival benefit, it's a win-win.
So one of the things about the treatment of prostate cancer is to try and calm it down, slow it down, make it dormant, quiescent. And that's been a big part of what we ended up doing in our clinic and what I do for myself. The idea of reducing the aggressiveness of the disease. And so in terms of laboratory work, metformin is very exciting because it appears to do just that. make aggressive disease less aggressive. Statins, the laboratory and clinical data on the statins are even more impressive in that regard. They really do appear to quiet prostate cancer in many patients. So those statins are cholesterol, Lipitor, Crestor.
It's more of a commentary on the MRI, the seed emplacement. I don't want the patients to realize. I do about 7 to 10 prostate MRs a day, and I've been doing it for 8 years. And I've done numerous patients with seeds. And the most important sequence, it is true that it messes up the MRI, but it is also true that if you have the proper dynamic IV contrast sequencing, which is not true on every magnet, then what you can do is that recurrence will be the first thing to light up in the gland, and that's what you do your targeting biopsy on. And I've had many, many patients with this. So you still should not give up on the MRI. And also at the same time, you should have the opportunity to look at bones and look at lymph nodes as well. And then also complementary at the same time is either the PSMA or the Oxumin scan. And you want to look at the raw data, because a very small raw data will show up with the MRI. And you put those two together. Both of them are efficacious if you do both together.
I'm reading a dramatic increase on the support sites. People going to Germany for the PSMA, not only scan but treatment. And the question is, they're trying, and I'm also looking at them, they're trying to decide at what point is it worth going there, because it's not available here, to get what looks like to be rather dramatic improvements, even visceral mets. The only downside seems to be damage to the salivary gland, which may not be a minor thing. But the question is, what are the parameters that you might want to use to weigh whether it's worth going there?
I've had quite a few patients from Australia in my clinic population, and the lutetium PSMA treatment and the gallium PSMA scans are widely used in Australia. And they certainly have responded, but the response has not been very durable. So I really don't know what to make of that. I don't know where that, I have no question that some patients will respond, that there's therapeutic activity, but for the life of me, I don't know where to put that in the flow diagram of treatment.
Just to clarify a couple terms, when you mentioned lutetium, is that Lu-177? Lutetium is Lu-177. If people were to Google that, yeah. And then he mentioned visceral mets. What is visceral, just for our audience?
In your viscera.
Soft tissue.
Soft tissue, okay. Liver.
Yeah.
But not lymph node. Lung.
Thank you.
And liver, but not lymph node.
It's a word that's becoming more common in MCRPC.
Yeah.
It's a brand new word.
In organs, but not lymph nodes and not bone.
Thank you.
So just to be clear, there are actually 3 injectable forms of radioactive therapy in clinical trials right now in combination with PSMA. One is lutetium-177, the second is iodine-131, and the third is a gallium-68 product. The gallium-68 products are actually being used, I think, with different forms of PSMA in different clinical trials. In places like Australia and Germany, these products are fairly well advanced. Trials in the US have only just started. But we really don't know how well they're going to work for most patients yet, and we don't even really know exactly who the best patients to treat with these products are. They're going to go through the usual process where we start with the patients who have most advanced disease and have failed everything else because they're the patients that most in need. But probably they will work better slightly earlier than that, and it's going to take time to work that out. So do we have any other questions?
Quick question, Mike. Would you add actinium to that list?
Sorry, actinium-225 is another one. Yes, I'm sorry.
Thank you.
Well, one thing that we haven't covered today, and Jen and I were talking about that, and that is the whole idea of treating oligometastatic disease, and then that was part of your story too. and it also relates to these improved scanning techniques. And so the study that got this started came out of University of Rochester. Ed Messing was the urologist on it, and then the guy from the radiation therapy department. And they followed patients with bony metastasis over time to see if the extent of disease made a difference. And so they had three groups of patients. People with PSA recurrences without bone mets, people with bone metastasis with 5 or fewer lesions, and those with more than 5. And the striking thing is people with 5 or fewer lesions seem to do as well as the people without any bone lesions at all. And that in many cases, repeat scans showed the bone scan positive lesions were stable. So they then and then after a period of time, those stable lesions would explode. So they then argued, well, if we treat these lesions with radiation therapy, when they're sitting there doing nothing, perhaps we can make a difference and put the patients in a disease-free state for a while. That paper, which was published in 2004, has triggered the whole field of this. And in fact, at this point, it's clear there are patients who have 5 or fewer bone lesions who have those lesions radiated who can go many years without recurrence. There are also people where you radiate those lesions and cancer everywhere explodes. And the problem is we're not yet very good at telling who's going to be in what bucket.
One of the questions that it was asked years ago are, do metastases metastasize? And the evidence would suggest that, yes, sometimes they do. So if you radiate these localized areas of metastatic disease, not only do you control them locally from getting bigger where they are, but stop or at least discourage cells from breaking off and going and setting up shop somewhere else. So as Snuffy said, when I had the L1 and L3 vertebral metastases, which would make me oligometastatic with 2, I had them radiated with stereotactic radiation to sterilize them in place and hopefully not be the source of metastases subsequently.
So I'd like to take a step back and just talk for a few minutes about nutrition. Obviously, this is a subject where lots of people have opinions. We have very little definitive trial information or anything, but I know this has been of great interest to you, Snuffy, and I think it's been of great interest to Paul as well. So just be interested in what you basically think about people should try to do in terms of diet, exercise, whatever else you think is a useful thing for them to investigate for themselves. Some things work for some people, some things don't work for other people, but I think your opinions on these would be of interest to everyone.
A heart healthy program is a prostate healthy program.
A heart healthy program is a prostate healthy program.
So, yeah. And so what we do is have our patients on a heart healthy diet. I'm an advocate of the Mediterranean diet because it's one that's easy, and there's a randomized control. And my wife is Sicilian. So if I didn't say that, I'd sleep on the floor. And exercise, of course, there are now good clinical trial data on exercise.
The Australians have done a lot of work on clinical trial data on exercise. There's a lot of information now to suggest that it's not just a matter of going and walking around the block for a mile on a regular basis, that you actually need to work up a sweat and get fit if you can, or at least as fit as you can. And that is also going to be good for your heart. And if you want to live to 90, you'd better have a heart that's functioning well, because otherwise you ain't going to make it, guys. So, I mean, I don't think that, I mean, while we know that some people, for example, do really well if they have metastatic disease and they're taking Lupron, if they're on some sort of soy-based diet or it's a big part of their diet, some men do really well with that. Other people it doesn't seem to make any difference with. We don't really know why. So sort of individual things about you should eat this, you should eat that, you should eat the other. They work for some people, but they don't work universally. Jan, I think there's a lady with a question right over there.
Sure.
At one point, pomegranate juice was advocated as the preferred juice because it would slow prostate cancer. I talked with Dr. Charles Schultz, who said the study was actually done in his office, and it was a very small group of people and never replicated or duplicated. And he's not sure that it actually is something that we should continue to do. Any comments on that?
Well, I'd like to broaden it and say that the whole issue of diet and supplements is complicated. In the laboratory, there are a wide range of nutritional elements and supplements that have very impressive activity in the laboratory. The problem is getting evidence that that's true in humans. And for a variety of reasons, the clinical trials that have been done have usually not been very good. So I'm left with this frustrating situation where I know naturally occurring chemicals that could potentially have major therapeutic benefit, but they've never been studied, so I really, in fact, don't know if they work in people. The other thing is that some of the most active chemicals in the laboratory are poorly suited to be drugged. Resveratrol, curcumin, they all are poorly absorbed from the GI tract, rapidly destroyed by the liver, and so have great difficulty reaching the cancer in my patient in a significant concentration to make a difference. And so that just adds to my discomfort based on the lack of sound clinical trials.
Snuffy, do you think that the large amounts of sugar in juice in general are a problem? Because I've heard that referred to before. Or no?
I'm sorry, I missed it.
The large amounts of sugar, say, in juice, like in pomegranate juice.
Oh, yeah, well, the pomegranate clinical trial, the first part was a phase 1 trial where they were increasing the amount of sugar, and they had to stop at, what was it, 6 ounces or 8 ounces? Because their blood sugars were getting elevated in the pre-diabetic range.
So would you say pomegranate capsules might be worth considering over juice, or pomegranate itself?
Well, again, you know, a pomegranate, there was a very interesting phase 2 clinical trial from UCLA that showed promising activity in slow-growing prostate cancers. And it looked like a perfect agent to add to patients with recurrence with a slow-growing cancer or in the active surveillance setting. But the randomized controlled trial that followed that didn't document anything.
I've been hearing that like 90,000 heat unit pepper, like in a capsule, supposedly can really help deal with prostate cancer. Have you heard of...
You mean hot pepper?
Yeah, but like really hot pepper, like 90,000 heat unit. You basically don't use it in your food. You take it in a capsule.
So there was some laboratory work where they took human prostate cancers and transplanted them into mice and fed them hot pepper. And they showed slowing the growth of the cancer. And when I went through and did the calculation of how much that would be for a human, it would be 6 to 8 habanero peppers a day. And so I just put that in the back of my mind, thinking that's not something I get away with, and until I had several patients who found no trouble doing 6 to 8 habanero peppers a day. And anecdotally, 2 of them had a slowing in their PSA doubling time.
So it kind of take you back to heart healthy is prostate healthy, and it's a great landing
My
place.
reaction is I'm not sure cancer is worse than the habanero.
Mike, is it difficult to take information in mice in a clinical trial? Does it always transfer to humans? Because my understanding is no, and that's one of the hard understandings. You find a study online about mice, and you think that must be everything, but it doesn't always transfer to humans, correct?
Snuffy, you're the lab person. It doesn't, correct? I mean, mice and men are not in the same equation.
The life cycle of a mouse, as far as I remember, is about 100 and something days, or a couple of hundred days normally. I mean, they just aren't around for 70 years. And the things we do to our bodies over time are very different to what a mouse is going to do to its body over time. So I think you have to realize there's a whole different metabolic process going on, quite apart from the difference in the genetics and everything else. It is routine within the pharmaceutical industry to test drugs on animals before you test them in humans. For every 10,000 drugs that goes into a laboratory study, one makes it to market. Whatever they did in the mice or the rats or the dogs or the whatever else along the way, the risk for the side effects is so high in humans by comparison with the risk for the side effects in the animals because, unfortunately, we don't think animals are quite as important as we are. Well, some people do, and they may well be right. But we kill an awful lot of animals in the attempt to find things that will help to cure our problems.
Another question?
So I think you're asking are the drugs like Casodex or Xtandi have less cardiovascular impact than Lupron and Eligard? Is that?
Yes. I don't think that's true.
Yeah, I would agree with that. They're both ways of blocking the activity of the androgen or testosterone and other androgens, and so the downstream side effect profile may be somewhat different, but I don't think there's any evidence that it's significantly or materially different.
Xtandi has a significant problem with hypertension, high blood pressure.
So the Prostate Cancer Foundation tells us that there are something like 27 different types of prostate cancer that they've been able to identify, or rather that the researchers working with them have been able to identify. Do you think that's even the right number, or do you think it might be more than that?
I think that it's like the map, the pictures that show the United States from Manhattan. And New Jersey's pretty big, but by the time you're in Chicago, everything disappears. We're not close to understanding.
And I think that's a very important point for everybody to understand. There are so many things that affect the way our individual biology works. As Lenny Gamella said at the beginning of the day, prostate cancer is not something caused by a gene. Every single day of the year, I think I see a new paper where somebody claims they found yet another gene that may have something to do with prostate cancer. Now, I don't think that's probably true that they all do, but we've probably identified thousands of genes now that may have something to do with how prostate cancer progresses in certain subgroups of patients. And if you start to take that back to, well, how many of these things are really important, given the broad spectrum of the way we are made up as multiple different ethnicities and races and whatever, my bet is there are probably hundreds of different types of prostate cancer. And we're really only at the beginning of trying to work out what all those are. So we have one more question.
Okay, I want to comment on that because I think it's important for people to understand that prostate cancer is science. And the nature of science is to make discovery, which creates change. So it does change every year. So it's a train that we're all on, and I expect change every year. So that goes with science. One more question.
Yes, I've been living well with prostate cancer for 7 years. I'm on active surveillance. I have a low-risk variety. And if there's one thing I'd like to know is there any way to tell whether I will have an aggressive variety at some point? Or can I be pretty confident that it'll just stay low risk and that I'll be fine? I guess I'm looking, is there a biomarker or something that can give me an indication or a test, that I've got that I harbor a high-risk variety of prostate cancer? Or transition to it, right, exactly.
So maybe I can just say one thing first. The fact that you have low-risk prostate cancer and have been on active surveillance for 7 years is never going to stop the possibility that will be a new spontaneous mutation that causes aggressive prostate cancer. In other words, it's not just about whether you might progress, it's about whether something else might happen. I am not aware of any test at the moment that can tell you definitively that you'll be able to stay on active surveillance forever. But you may.
So Klotz, Dr. Klotz at Sunnybrook in Toronto, well, the man who really got active surveillance started, has claimed that it's rare for a true Gleason 6 to progress.
And that's been...
That is a statistical rare event. But of course, the Gleason scoring is not perfect. And the whole purpose of tests like Decipher are to look beneath the pathology appearance at the molecular level, at various genes that determine aggression independent of the Gleason.
Okay, so thank you all for coming today. Thank you, Paul and Snuffy, so much for taking some time and talking to everybody.